Okay, we're going to go ahead and get started. It's 2:33 p.m. on Eastern Standard Time. So I want to welcome everyone to the Cervical Cancer Project Highlight. We're focusing on prevention and implementation models. In this panel discussion will actually be led by a team of MD Anderson experts who have been in this space for a really long time, have a lot of information to share. And thank you for those who submitted your questions in advance. Just by way of a couple of, let me get, Monique, are you handling, or we have a few more people in the waiting room? I'll let you get those folks in. Okay. All right, so just want to highlight our panels. Today we have Dr. Ellen Baker, who's here. She's the director of the Project ECHO in cervical cancer prevention in the Department of GY and Oncology. We also have Monica Pippin, who is the program manager for the program to reduce cervical cancer. We have Jane Monteligre. Jane, can you help me? I don't want to chop that
No,
up.
you got that beautifully, Jane Montalegre. Perfect.
All right. So Jane is associate professor at MD Anderson Cancer Center, a focus her department of behavioral science. And then last but not least, we have Melissa Lopez Veron, who is the program director at MD Anderson. So we have a really great panel this afternoon. And so the goal is for everyone here to go away with a thought and idea, something that you can implement real time at your own health centers to continue to expand and improve upon cervical cancer screenings. So this is a CME accredited panel discussion. So if you are here and you need continual medical education credits or CE, just want to let you know that this panel discussion is brought to you in collaboration with the Moses Weitzman Institute. These are accredited, so you are entitled to one CE credit for attending for the entire hour. You will receive a link in the chat. You can access that link to complete the registration to acquire your CEs. And without further ado, now that we have that out the way, we're going to go back and we're going to start the panel discussion. I'm going to ask each panelist to introduce herself. And we will start with Jane, only because Jane is the first person on my screen at the top right, so top left. So Jane, introduce, and then we'll get right into, after introductions, we'll get right into questions. So Jane, welcome.
Yes, hi. Thank you so much for having our team invited today. This is really wonderful. I am an associate professor at MD Anderson. I work with this broader cervical cancer prevention team that we have here. And my area is really in thinking about how we improve um, cervical cancer screening and also primary prevention with the vaccine in safety net health settings. So I do all of my work in FQHCs and a lot of work in our county large health system here in the Houston area, but also thinking about other safety net settings, of course, including community based programs. And I will be talking about self-collection, which has really been the focus of what I've been working on over the past decade and a half or so. And so really excited to share some of the work we do. Thanks so much.
All right, we have Melissa, and then Monica, and then Dr. Baker.
Hi, everyone. Thank you so much, Tanya and Monique, for the invitation. My name is Melissa Barone. I am one of the directors at Global Oncology at MD Anderson and have focused a few years, I'm not going to say many, many years, in developing a multi-component intervention for cervical cancer prevention in medically underserved areas of Texas and beyond Texas. We're excited to share more details with you in a little bit. I'm also the co-chair of a team working on developing a strategy for the elimination of cervical cancer in Texas. And very happy and pleased to be here with our team and with you all today. And I'll hand it over to Monica now.
Hi, everyone. Good afternoon. I'm Monica Oliveros, Program Manager at MD Anderson. I am one of the team members for Melissa and currently working providing education and training for our patient navigators that we have through one of our CPR grants that focuses on cancer prevention and screening. So most of what I do is work with the navigators and try to help them with any resources that they might need in order for them to better assist the patients that need to be screened or patients that have been diagnosed with cancer and kind of navigating them through the system. So happy to be here and hopefully I'll be able to answer some questions.
And hi, I'm Ellen Baker, part of this team. We have a larger team that's not all represented here, but I have worked along with Melissa and others for more than 10 years at MD Anderson to reduce the burden of cervical cancer, both in Texas and in other parts of the world. We do similar projects in parts of Africa and Indonesia and have provided assistance and support to other countries who are interested in improving their cervical cancer screening and improving the treatment of women who screen positive so that we make sure that nobody gets cervical cancer. Thank you.
Thank you, Dr. Baker. So to set the stage for this panel discussion, we have our first question. Can you just please briefly describe the cervical cancer prevention challenges your team are experiencing today, and how are you addressing those challenges? So we should probably start with one challenge. This is a broad question here, so let's just chunk it down a bit. So if we could describe your current prevention, one challenge, and then share with the group what your team is doing to address that particular challenge.
Maybe I can get us started, and then I'm sure others can think of other different challenges. We actually did a survey a few years ago across the state asking this specific question: which one is the most prevalent challenge or barrier to cervical cancer screening, early detection? And the majority of professionals indicated that there was not enough training or capacity for treatment of abnormal cervical cancer in different areas of the state. So that's why we are working with providers, so doctors, nurses, nurse practitioners throughout the state in medically underserved areas of Texas to receive telementoring using Project ECHO and to participate in in-person trainings to build their capacity and confidence to perform some of these procedures.
And if I just might jump in as well, if you don't mind. What we've learned over the years is that there is not just one problem, it's all interrelated, and any interventions that you're interested in looking at really have to be multi-component interventions that address in parallel and synergistically all of the major issues. And every community will be different, every individual patient will have different challenges. And so it's very important to look at the big picture and make sure that you're prepared to accommodate whatever those challenges are. And our program has grown over the last 10 years to incorporate more of those challenges as we get a little bit smarter and as we expand our area in which we're working.
Monica, maybe you want to talk a little bit about lack of patient knowledge or awareness of these services?
Yes, working with the navigators, a lot of the challenges that we encounter are the communities that we work with are a lot of lower income, and there's a lot of barriers when it comes to, there's a lot of language barriers as well. So then one of the barriers that I have with my navigators is making sure that I provide the right education so they're able to communicate with the patients and kind of meet them where they are, depending on the literacy level. And so that requires a lot of training on our end. And like Melissa mentioned, one of the things that we try to offer through our grant is a lot of training. And so we offer trainings twice a year for navigators and for providers. And for the navigators specifically, we try to provide training so they're better able to communicate with the patients, and they're better able to provide the education to get them in for screening and also for the navigation if they are diagnosed with cancer. And that's really an ongoing thing, and the barriers change as the time passes. And we always encounter different barriers, and we always kind of try to discuss and see how we can best help the navigators so they can best help the community.
Great.
And I think just to sort of add another perspective from sort of the things that we're going to be talking about today, which includes navigation and the capacity building. And the other thing is the self-collection. I think the reason we've really focused on self-collection is because one of the problems that we've heard is providers really want to, of course, deliver the best care for their patients. But especially when we're talking about safety nets and complex populations, there's a lot going on in that short visit that patients have. And so, I think for many years, what I heard was that we were, constantly telling providers, look at your quality metrics for cervical cancer. And the general sentiment was, okay, but give me a tool that I can actually use that will allow that's something that my patients can do. And it's something that I can do in the time that I have my patients. And so I think what's been really exciting for self-collection is I think we finally do have a tool that makes it possible for providers to be able to include cervical cancer screening in that visit, and also give an opportunity to patients to have a new way of doing things that may open up new doors that they previously didn't have, in terms of their ability to or acceptance of undergoing screening. And so really kind of addressing that twofold sort of problem about we want to do what's best for our patients, but we also have a lot of other things on our plate, and we need something that allows us to provide the best care, but also within the constraints of how we practice.
And Jane, it's okay, I hope, Tanya, for me to jump in here, but self-collection sounds so simple. I mean, you take a sample and you send it to the lab, you get a result, but I know there's a process involved in incorporating this type of cervical cancer screening into a clinic setting. And I wondered if you might just spend a few minutes talking about some of the challenges and some of the strategies to transition from the screening that we've been used to for 60 or 70 years and this new mode of screening.
That was perfect, Ellen, because that's a question here, to explain how self-collection can be incorporated into the clinical workflows at our community center. So that was perfect.
Oh, good. Oh, excellent. Yeah, no, wonderful. No, and this is I think it's really exciting. So, the FDA in 2024 approved self-collection in a clinical setting, which is just really exciting for the reasons I mentioned previously. It really does give us an entirely new method that really addresses a lot of our provider barriers to screening and of course our patient barriers to screening. And so in the year and a half that's followed, we've seen the revisions to the American Cancer Society guidelines. We've now seen the HRSA Women's Service Preventative Service guidelines revised, which is super exciting and I think so impactful in how this is being now kind of considered for health centers. And then of course ASCCP and the U.S. Preventative Services Task Force guidelines that are sort of still under review, not published yet, but in draft form. And so all of this really allows health centers to really think about incorporating self-collection as we like to think about it as an additional option. So I know previously there was a lot of push to really kind of, huge paradigm shift, switch from cytology over to primary HPV, and redo our laboratory systems and kind of really fully change practice. And what we've heard from providers, and this might be something that's been a sentiment that you all have felt, is we have actually a pretty good system for the patients for whom it works. And so we don't really advise that we overhaul what you're doing in your health centers, but really offer it as an additional option for those patients for whom self-collection might be preferable or might be the only acceptable or accessible option. And so offering it again just as an additional sort of screening tool. Like I said, it's available for use in the clinical settings. And so everything that we've been doing right now has been focused on how do we integrate it into clinical workflows. And I do want to just mention that while, of course, this is really the big push right now, and I think it's the most important, probably the most impactful for the safety net population, there will be opportunities in the future for us to think beyond the clinic. And so we might want to just start thinking about, well, what will workflows look like when we can also do this through telehealth and through a mailed kit, for example, to women's homes. But for right now, what this looks like in the health centers that I've been working with and within our safety net center is really offering the opportunity for screening to be routinely offered within adult medicine visits. So a patient's coming in for whatever they're coming in for, and they're due or past due for screening. And through a process, and this can be different by very providers. Some providers don't offer pap tests or co-testing within their usual practice, and they might be referring their patients to like a women's health, but have concerns about whether their patient's actually going to go to women's health. That patient would be a perfect indication for here's a self-collected swab that you can use while you're at the clinic today. Other providers may be already doing cytology or co-testing within their usual visits, but it's not it's not their main priority. It's not how they're doing. It's not the patient's main priority. They're managing many health things, and so being able to kind of shift off the time that they're previously spent doing screening onto handing off a self-collection swab so that they can do it off-site. And so there's very, very many ways that this can be integrated. And what we've done really is, I do want to put in a plug because it's not something that is out of reach for health centers to do. It is actually, if you kind of break it down, just a couple of tweaks that have to be made to your work orders and to your processes. And so we've really tried to refine this and really put this into a small and usable document that clinics and health centers can use to integrate self-collection into their practice. I think we can put the link over here, but it's something that we've been implementing through with the clinics that we're working with here in Texas, as well as my colleagues in Illinois and Washington, Oregon, California area. And it's really kind of just breaking this down into one, make sure that your lab offers self-collection. At this point in the game, most do. I know, for example, in Texas, we have LabCorp, Quest, and clinical pathology laboratories are our big commercial labs. All of them have started offering it. Most of the reference labs that you might be using are also offering it. So just establishing that you can do this. Second, tweaking your EHR to include the order for primary HPV, because self-collect really is primary HPV testing, which has a different order from the current order for co-testing. And then once that's done, just making sure that it's being pulled by your UDS measures, your HEDIS measures. I will also be happy to say that at this point in the game, now February 2026, most of this is actually already built into how the quality metrics are pulling the codes. And so there's actually very little manual work that needs to be done on your part to make sure that your quality metrics are including this. And then once those sort of technical aspects are happening, then it's really about training staff, and by staff I mean everybody. So this is self-collection really is everybody, all hands on deck. In our clinics, we've seen the medical assistants have a huge role in really talking to the patients about self-collect, making them aware that this is another option, taking away some of the burden from the providers in terms of doing the education for the patients. We've also seen the clerks and the front desk staff oftentimes are the ones who are getting the first questions about, like, is this really something that's new? Can I use this? Is it valid? And so really training everybody and motivating everybody. This is a big cultural shift in how we do screening. It's also a big shift. And so, it's not a plug and play, let everybody know that this is available and all of a sudden miraculously everybody starts to use it. Not by any means. So it really is an ongoing process to make sure that everybody has their questions answered and is motivated to use it. But then after the training, really just monitoring, making sure that that it's working appropriately. And then of course, like I think Melissa and Ellen and of course Monica will talk about later, screening is just the very first part of this long process. And it's so important that we don't think about screening as a test anymore. Screening is a process. And so I think where the bulk of the attention really needs to go is in making sure that all of the patients who have a positive screening test are able to get the follow-up test they need. This may be something that can be done internally with the triage PAP test that's done on some of the high-risk positives. It might be colposcopy, which is also ordered internally, but then working with Women's Health to be able to do that. But sometimes for many clinics, that actually is a referral out to colposcopy. And so making sure that we have the referral networks so that we have a home where our patients can go once they have a positive test and need follow-up for a 16-18. So about 3% of patients will need that colpo follow-up and about 7% need a follow-up PAP test. And so really making sure that we have a system in place to make sure that they are able to get through the whole care continuum. And then, of course, just monitoring progress and a lot of quality improvement to make sure that we're addressing all of our patients' questions. Oh, sorry, my dog is not liking that I'm talking. But I really, again, would like to put a plug in for this guide that we've developed that also includes downloadable templates and patient education materials that can be branded and whatnot. Our idea is really no one should be reinventing the wheel over and over again. Let's learn from what others are doing and kind of pool our resources and make the lift a little bit easier.
Thank you, Jane. I have you mentioned screening as a process, and I'd like to come back to that later. So I thought that was really good. We should probably get that printed someplace. It's like screening as it is a process. It's not separate from what we do in our clinic day to day. But getting back, staying on the topic of the self-collection. So we all know that there's some resistance, right? So there's some provider resistance around this self-collection tool. And concerns are really basically around the accuracy, or is the patient, is the patient doing this correctly? And so how are you addressing that? So, for those of us who are sitting on the sideline saying, oh yeah, this sounds great, but we're not sure if we want to adopt that yet or make that a part of our process. What would you say?
Yeah, absolutely. I mean, this is again like a huge shift in how we do things. I think what's really important to know is the FDA was very strict in its review of self-collection. For those who might be watching this on the international stage, self-collection has been for many countries has already been used in their cervical cancer screening programs for quite a while, and the FDA I think had some really high bars in terms of what data were needed to be able to show that it could be used. And so I think the FDA approval in itself is really an important reassurance because it is a very rigorous process that went through, as well as post licensure testing through the National Cancer Institute's SHIP trial, and then the evidence reviews that were done by HRSA and the U.S. Preventive Services Task Force, or the U.S. Preventive Services Task Force, which informed HRSA, as well as the data reviews from ACS and ASCCP. But just to summarize, those data really do show that. So I think at the crux of this is we know that really, since we've known about the causative role of HPV, we know that HPV testing is a better predictor of risk than it is cytology. And so when we have cytology-based screening, HPV far more outperforms that in terms of how well it's able to detect women and people with the cervix who are at risk. When we have PAP testing and HPV testing together, we have, two tests. And so there is concern that if we take away one of the tests, are we doing less for our patients? And I think that's an absolutely valid concern. But the data really show that truly the performance of co-testing is really driven by the HPV test, not by the cytology, to the point that we can actually omit the cytology and have similar sensitivity when we're talking about detecting clinically relevant disease, so high-grade SIN2s and SIN3s. And then at the same time, it also allows us to reduce some of the unnecessary procedures that we have when we also do cytology. So cytology does provide more information, but that information more often results in unnecessary colposcopies than it does in actually something clinically useful. So, but I do see, like, getting rid of that visual cytology is a hard ask for people. It is sort of a very much a paradigm shift. So in terms of HPV, that's really the evidence. It's a superior test to co-testing and to cytology. Where I think people also get concerned is, can a patient just like a provider? Can we take, are the samples equivalent? And I think, again, this is an excellent concern. And like, there is no way that the sample, that a patient takes is going to be okay, is going to be the same as a provider. The nice thing about self-collection is that it's actually a vaginal swab. We don't actually need cervical specimens for self-collection. And so, whereas for a cervical sample, yes, you absolutely need a provider. You absolutely need someone with a speculum coming in there and reaching the cervix and taking an adequate sample from the endocervix and, and sort of that region in there. 100% that needs to be a provider. But the vagina actually has a lot of HPV from the cervix that can be captured with just a simple swab. And so this has been shown in many, 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 many studies that show that the correlation between a provider collect and a patient collect is actually pretty much on par. So there is no hit in terms of the patient taking it, again, because it's a vaginal sample. With a vaginal sample, of course, there are restrictions to how we can use that. So, for example, like I mentioned, some of the high-risk positives need to have a triage PAP test to inform how we manage that person clinically. That triage PAP test can't be done with a vaginal sample that was collected by the patient. So that patient's going to have to come in to have a provider take a cervical sample, which is what we need for the cytology. And so for that patient, for those 7% of patients who will have a high-risk HPV positive that's not 16, 18 and sent directly to colposcopy, for that 7%, having done it through self-collect is actually going to result in them having to have those 2 visits, with the second one being a provider collected pap smear. So yes, so it all in all, I think, just to summarize, HPV testing is highly accurate. It's a driver of performance in all of our screening tests, and doing it alone doesn't confer any inferiority to doing it with a pap test. And we know that women and people with a cervix can take a vaginal sample just as well as a provider, albeit when they actually need a cervical sample, then that's when they have to come back in.
Okay. Thank you, Jane. Anyone else from the MD Anderson team would like to add additional comments to that or views before we move on?
Oh, that was a great summary, Jane. I guess I just want to remind everybody a cytology, a PAP will miss 50% of CIN2, and HPV test will miss less than 5%. So like Jane said, it's a much more sensitive way to find precancerous lesions on the cervix. There'll be some false positives with the HPV, but it's still a much more sensitive test. And in all of our studies and many others, women prefer to take the sample themselves and forego the speculum exam, but it's a process that people have to get used to. Women didn't like to give up that annual PAP when we did that a few years ago, and now that we're transitioning away from a regular PAP test to HPV testing, I think it will take a while for people to be comfortable and have confidence in this screening method.
Thank you. Thank you,
Yeah,
Ellen.
absolutely. And just that Ellen made me remember just one other thing. And I think, we don't, again, I think I probably said this, we don't want to replace current screening methods. If a woman is able to see their women's health provider or their family provider, family medicine provider is already kind of doing that comprehensive women's health, that's really important. There's other reasons other than cervical cancer screening that we want women and people with a cervix to have that care that they need. So again, this is really just having an option. And I think really where self-collection is most important and most effective is that we know from data from the US and from all over the world that we can actually double the participation amongst underscreened individuals. So people who are not up to date with their screening, if we offer them, come in and see your provider for the traditional test versus, hey, alternatively, we can give you a kit. We know that twice as many people will participate in that second option. And so really, I think for the community health centers and for all of the places that are really seeing patients who might be underserved, might be underscreened according to the guidelines, this is a effective way to really kind of use your resources into something that is going to have much higher return rates for your invested time and energy than our other methods like those recalling and reminders.
And I guess, Tanya, just the last thing I would say is that sometimes the challenge to implementation is not knowing where to start or how to make that shift or how to educate your providers or your clinic members. So I would say besides the manual that we're sharing in the chat with you, we will be sharing an exciting opportunity. Dr. Montealegre and Dr. Parker from MD Anderson are starting a new Project Echo series to help clinics that are ready for making that shift, ready for implementation, and really don't know where to start. An opportunity to come and have discussions and learn from each other so that the time from knowing to implementing gets shortened, and then we can benefit the women that, as Jane said, might have the challenge or barriers to that pelvic exam. So more to come.
Yeah, great. Thank you. We love resources. We love support, that hands-on support. So thank you for that. And that was great that you mentioned Project Echo, because I'd like to take a few minutes to talk about Project Echo for you to share with us what role does the Project Echo model play in your cervical cancer initiative? Jane mentioned staffing, and I still have that part here. We're going to come back to, you mentioned training, staffing, but share with us Project Echo for those in the room who aren't familiar with that. Tell us about that, and how does this model really differ from your traditional one-time training models that we see across our health system?
Ellen, do you want to get started?
Sure, I'll get started and the rest of you can jump in as needed. Project Echo has a unique name, but really it's a video conference that connects provider to provider. It is not telemedicine. It is an opportunity for specialists to connect with community providers and providers in under-resourced regions that perhaps don't have access to specialists, and discuss cases, so it's case-based, and to continue learning about whatever the topic at hand is. For cervical cancer, we have been running a every other week Project Echo since 2014 with providers from around the state of Texas, nurse practitioners, doctors, nursing students, medical students, And we come together for an hour on Friday mornings to discuss particular cases that people might have a question about, and for one of our faculty to provide a brief lecture on a topic of interest. But it's a little bit more than that. I mean, that sounds fairly simple, but I think, all over the long term, this is an opportunity to create what I call a professional network. So particularly among providers and in clinics that were fairly rural or isolated, who felt very much alone and out there all by themselves. This has brought together a community within the state of people who all face similar challenges, who are trying to provide this service in the best way possible. And it also gives them access to our faculty so that when they have questions, they know who they can go to get answers. I kind of call it the glue that holds all of our different implementation tools together. It's an opportunity for us to meet on a regular basis, to know each other. We visit our partner sites so that we know what their clinic looks like and what their challenges are and what their patient population is like and the context in which they're delivering care. We come together a couple of times a year to have in-person training on cervical cancer screening and treatment of women with pre-invasive disease, so colposcopy, cervical biopsy, LEAP, etc. So like I said, it's part of the glue that holds this community who's providing these services together. Melissa, I'm sure you have something to add.
No, I think the only thing is everyone's invited. If you are at the clinic making sure that patients are being screened and you don't know what to do or are not sure which guidelines to use and how to follow these patients that have abnormal screening results, join us at the Echoes. We have one this Friday. We put the link for registration in the chat. We want you to be part of this community regardless of which state you're participating, as long as it works with your schedule. And the meetings are on Zoom, so you can join with camera off or camera on and present your own cases. And then Monica has shared also the information for patient navigation, because we have an echo for patient navigators. Monica, if you have your hand raised.
Yes, sorry. I just wanted to add, just similar to what Dr. Baker just mentioned, we have an addition, we have a lot of echoes at MD Anderson, but specifically for our grant, we have the cervical cancer prevention one for providers, but we also have the pen echo, which is focused and it's targeting the navigators. And I run that echo, and that echo was created in order to better serve the navigators across Texas. We also have people joining from outside of Texas, but mainly our navigators through our grant that are seeing patients that are getting screened for breast, cervical, or colorectal, and it gives the navigators the opportunity to present cases for any patients that they're seeing and present any barriers that they might be having in getting that patient to care. And so just like the invitation is open for the cervical cancer prevention one, also wanted to open the Pineco one. And I've included the link on the chat for anyone that might be interested, any navigators, or if you want to share with others, happy to see you guys. And we actually have our next Pineco on Monday, the 16th. So we have the one this Friday for the providers, and then we have the one for the navigators on Monday.
And I just wanted to say, I think, like Ellen said, this really is the glue, especially when it comes to new services that are being implemented. I know, through the project that Melissa and Ellen and Monica are talking about, one of the big things has been capacity building around colposcopy and treatment of precancer. That's a new practice for many health centers. That's something that they're newly doing. And then, of course, self-collection is new to all of us. No one really knows what we're doing. We're all really learning from each other. And so I think the really sort of that model, that community of practice has been so important, because the learning that we do sort of adjacent in there's no expert saying this is, I mean, I guess for colposcopy and things like that there is, but when it comes to like implementing self-collection, this is all brand new. A lot of the best practices are being established right now by the people who are implementing the innovative ways that you can do this, by leveraging your MAs, for example, that's being invented, that's being developed by community health centers right now. And so that way to sort of diffuse information, best practices, kind of bounce ideas around, ask people what failed, what worked, and have a space for that, I think has been extremely, extremely valuable, especially for these new pioneer community health centers that are really kind of being the very early adopters of these new technologies, but also for community health centers that are, like, again, embarking on adding services like colposcopy and treatment into their clinics for the first time.
Thank you for sharing the Project Echo. I know it's a wonderful opportunity for what I look at as global networking, right? So it's expanding your ability to network across states. And I'm not sure if you have international as well yet in your panels in your group. But I do have a question here. There's one question that said, what implementation challenges did you encounter as you designed and developed Project Echo, and how did your team adapt to those challenges as you began to build out? So let's just take this one piece at a time. So what was one implementation challenge did you encounter while you were building out Project Echo?
Let me just say a few things before we answer that. If you want to call the video conference that you're having Project Echo, you need to, your institution would need to agree to some terms. It's run by the University of New Mexico Echo Institute. And then somebody on your team needs to receive training in Project Echo. And we provide that training at MD Anderson. It's 8 or 10 hours, I think, of training, which is all done remotely. So once you do this and you learn what the Echo format is, and you've agreed sort of to the terms of holding your conference that's called a Project Echo, then you can have an Echo. And there's many challenges, I would say. I'll start, Melissa, but identifying needs, and when I say identifying needs, really, you need to know what the needs of your partners are. It's not a good idea to go into a community and say, I think this is what you need. So you need to be a good listener and work with your colleagues, understand what they need, and then you build your Echo program in order to fill those needs, because ultimately the goal is to build capacity so that they can provide better service, a wider area of service, more services for their patients. So it's a capacity building tool as well as a professional network. And Melissa, you may jump in for a few other challenges as well.
Yes, I think the other thing, we have been doing this for many years. We're supported by the Cancer Prevention and Research Institute of Texas. And people come and go. We have turnover for providers, participants, patient navigators, and that's one challenge that we see. I think to overcome that barrier, we're always ready with manuals of operations, standard procedures for the newcomers, and Monica spends a lot of time with the new members just acquainting them to what we're intending to do and why this is important, and also providing that regular training that people can join at any time. Our Project Echoes are open doors for people to come and go. So sometimes people are new and they're very eager and they join twice a month. Sometimes they feel very confident and they depart from us for a few months or a year and then they can come back. That's absolutely fine. I think we just try to kind of like reduce those barriers. Sometimes people leave into different systems and they stay with us because they see the value of, like you say, Tonya, being part of a network of people and then having those real-time answers from experts that are going to better serve their participants and the people that they see.
Thank you for share. We're about 15 minutes, maybe 12 minutes into closing. So I would like to spend the next 5 minutes or so, and we're going to open the room for questions. Please have your questions ready. We're going to ask you to unmic. But I just want to talk about the cervical cancer elimination plan. So Texas has a cervical cancer elimination plan. And I know you just had this big event. It was a 3-day event. And I would like you to share that plan or give some information, give some context around that. I thought it just was amazing. I had the opportunity to attend 2 out of your 3 sessions. A lot of work happening there in Texas, but just share with us, take a few minutes to talk to us. What is this cervical cancer elimination plan for the state of Texas?
Thank you, Jane. Thank you, Tonya. And I'll ask Jane and Ellen and Monica to help me here, but I'll just start by saying we are very excited in developing the plan. We are not done yet, but we have just started with a lot of enthusiasm from across the state. In 2018, the World Health Organization released this call for action to eliminate cervical cancer as a public health problem because we know what causes it. We have primary prevention with HPV vaccination. We have screening that can be made available even at the point of HPV self-collection at your home within your healthcare system. And we have treatment of pre-invasive disease and even treatment of cervical cancer if detected earlier that can save lives. So with all of these gamut of interventions, we think that cervical cancer can be eliminated. Many countries are on their path to eliminating cervical cancer very soon. We think that before 2030, Australia will be eliminating cervical cancer as a public health problem, and they will be the first ones. So following those steps, Alabama released the very first in the US strategic plan of action to eliminate cervical cancer in Alabama. This was done in 2023. And we can see that being a very similar state, we're also in the South, we're also very conservative. We have a lot of underserved communities. If they've done it, we can do it. So we are excited to hear from everyone in our state. How can we do this and do it better so that it's not something that we do and store in a shelf, but really that we can take on and implement so that we can also reach that path to elimination very soon. In your state, there might be other people working on it. I know the Southeast Roundtable is working on elimination as well. So I think some of you maybe introduce yourselves. If you are wondering about these, let us know, and we're happy to connect you with some of the states that are already ahead of the game. I know Louisiana just released theirs in January to commemorate Cervical Cancer Awareness Month. So we are hoping to follow those paths closely. And of course, anybody's welcome and invited to share with us your experiences and helping us be able to accomplish this exciting goal for our state.
Yeah. And I was going to say, I think in Texas, we're really wanting to do like an all hands on deck. Again, everybody plays a role, just like the best practices that came out of Alabama. And we are also very fortunate to have a very forward-thinking Cancer Prevention and Research Institute of Texas that is really embracing new technologies and new practices like self-collection. So how do we use self-collection? How in the future, I hope we'll have a point of care test, for example, but how can we use some of these new technologies to really mitigate a lot of the big barriers, a lot of the work, like for example, like this group is doing, again, putting colposcopy and LEEP in primary care and community health settings, for example. These are big new innovation practices that I think are really going to be necessary to reach that elimination. Unfortunately, the same old really kind of started to plateau about 20 years ago. We accomplished amazing declines in cervical cancer incidence and mortality starting in the 1970s. And it was just, almost 25 years of just, conquering a cancer. And unfortunately, right around the 2000s, we really started to see sort of this plateau in which we were able to accomplish in terms of cervical cancer burden. And I think that really reflects, some of the big access barriers, frankly, not just structural access barriers to healthcare, but also access barriers around, people's culture and what they're personally comfortable with and what is acceptable to them. And so that was really leaving out 20% or so of the population, a little bit more now. It's actually, we've seen even more declines in recent years. And so, how do we, really kind of use new tools to get to that 20% of people who are underscreened, who aren't screened. Similarly for vaccination, how do we do new things like school-based vaccination and mobile van vaccination in communities, for example, really, again, to not think about the population that's already taken advantages of these prevention services. Of course, we want to keep them excited and using them. We don't want to fall back with those populations, but really, how do we capitalize on that big need amongst 20-30% of the population, that really the current ways of doing things haven't worked, and really come up with some new tools that do work for them. So I think that's sort of a preview, although we haven't written the full plan. Like Melissa said, this is really in nascent stages and really getting everybody in Texas on board with this. But I think we're really going to look to Texas to embrace some of these new things that we've been talking about.
Yeah, so exciting, so exciting. I can't wait to see it unfold. And so I guess we better open up the floor now, open the room for questions. Any questions, feel free to unmic to ask your questions while we have our MD Anderson team here. Let's see, do we have any questions in the chat? Don't see.
No questions in the chat.
Okay, we have no questions for this amazing team today. That means you delivered your panel perfectly. So let's I guess we can continue then with closing thoughts. I can have each panelist just each of you share with group today. If you had to leave a final thought regarding cervical cancer screening, our path forward to eliminating cervical cancer, what would that be? So we'll just have you each share your final thought or words of wisdom.
I think I would say elimination starts at home. So talk to your family members, talk to your aunts and cousins and best friends, remind them how important it is to take care of ourselves, and also promote the HPV vaccine not only for girls but also for boys, and make sure that they follow through, because we're not only preventing cervical cancer. If we get the HPV vaccine, we can prevent up to 6 cancers. So just a reminder that we talk about public health up here, and it's kind of like, oh, policy, but what are we doing within our own areas of influence, and how can we just share the exciting news that we can dream of a world without cancer, without the very first cancer. 10 years from now, we're hopefully will still be alive and we'll be able to see that. So I just encourage everybody to start those conversations. And there's many tools that you can use if you have anybody that might have HPV vaccine concerns. So go take a look at the ACS materials and others so that you can be well informed. Ellen, you're unmuted.
Yeah, I would certainly second that, right? Good health certainly begins at home, but I think it's also important in this day and an age of a tremendous amount of misinformation out there, that the medical community really comes together and makes sure that we're delivering the same message, and that we're using all the tools we have to ensure that our patients get the very best care. I think misinformation is a tremendous threat, not only to cervical cancer prevention, but to a lot of other medical issues and health issues.
I think my words of wisdom. Oh, sorry, Monica, go ahead.
No, it's okay. Go ahead.
You sure? Okay. I guess what I spend a lot of time reflecting on is that cervical cancer really inherently is the sort of a visible way that we see inequity and some populations being left out systematically. And so I think I think it's going to take all of us. It's going to take everybody's voices being heard. It's going to take everybody having a voice at the table so we can learn about, what is keeping, what is, what is, why, what are the barriers? How do we address them? Like, how can we use some homegrown local fixes to do this? Everyone, yeah, thank you, Melissa. Everyone really has a role. And the reason everyone has a role is because when when everybody didn't have a role, we weren't able to achieve this. The only way we're going to achieve elimination is if everybody kind of really comes on and we really think about every population, every community. Until cervical cancer is eliminated everywhere, it's not going to be eliminated anywhere, so it has to really, it is kind of it has to be all folks on deck and all voices at the table. So that's my big picture take home.
And just to follow Jane, I think my message would be to focus on navigation. It's just meeting patients where they are. There's no perfect framework or program that's going to fit every patient out there that needs to be screened. And so just important for us to take the time to really listen to the patient, the community, and really find the barriers and not let any patient fall through the cracks. I think that's one of the things that we try to focus in our program is making sure that every patient gets navigated and just making sure that if we have to make that connection with other communities or any resource providers that are not even in the same city, whatever it takes, just making sure that we do everything we can to get these patients in and to get them navigated through the healthcare system.
Thank you, Monica. Thank you, Jane, Ellen, Melissa. I just want to thank you. We truly appreciate you taking time out to join us and to share what you're doing at MD Anderson and how you are combating and just fighting the cervical cancer war. And so I just want to close today and say, just to leave with this group, we've learned today that cervical cancer, the issue isn't whether or not it's preventable. We know that prevention is possible, but not only prevention, but we're working towards a plan of elimination. And so it's about whether or not our systems are reliable enough to ensure every patient, Monica mentioned every patient, that every patient completes the journey from screening to follow-up to resolution. And so if each of us leave committed to one concrete action, we all together can move closer to elimination. That was my takeaway. I hope everyone in this room has one takeaway, one thought, one idea, one strategy that you could take back to your health centers as we continue to move forward on the elimination of cervical cancer. So thank you all for joining us today. And thank you for all the work that you're doing out there on the front line as we focus on cervical cancer prevention and elimination. Enjoy the rest of your day. Thank you.
Thanks, everyone.
Thank you, everyone.
Thanks, Tanya, Monique.
Thank you.
Ciao.
Don't forget to snatch those links, those resources in the chat, guys. Don't leave the room without grabbing the resources.
Thanks so much, Tanya. Really enjoyed this, and thank you so much. And
Thank you.
wonderful work that all the folks on this excellent group are doing. So thank you. Really appreciate the opportunity.
Much appreciated. Thank you.
Bye, friends. Thank you.